And we're live.
So good morning, everyone. Let me welcome my fellow commissioners and the HPC staff and everyone who's able to join us for the meeting today. We are going to run the MOAT committee, Market Oversight and Transparency committee, from 9:30 to 10:30, and then we'll take a half an hour break. And then after that will be the second committee meeting, which will go from 11 until noon. Do I have that right, Colleen?
Yes.
Okay, terrific. So if we can just jump to the agenda for today. So we're going to start off, obviously, as we always do, with the approval of the minutes from the last meeting. Then we'll talk about the registration of provider organizations, and then some of the highlights from the 2020 cost trends report. And obviously, it was an unusual year, so I'm sure we're going to have a lot to talk about there. So let's then start off with the meeting minutes from our meeting in February. And someone needs to offer a motion to approve the minutes. Okay, thank you. And then a second for that?
Second. All
right, thank you, Cassandra. So any additions, deletions, suggestions for the minutes, excuse me? Okay, if not, then we get to vote. Colleen, do we need to do this by a roll call, Colleen?
We do, and I'll just take a quick roll call of the Market Oversight and Transparency Committee members. We do have some Care Delivery Transformation Committee members here today, which is wonderful, but I'll start with you, Professor Cutler.
Approve.
Commissioner Roeder.
Approve.
And Commissioner Haupt.
Approve.
Thank you.
Okay, very good. So let's then move on to the discussion of the RPO. Colleen, shall I turn it over to you to introduce this?
Actually, we'll turn it right over to David Seltz.
Oh, I did not see David's picture.
He's here.
There he is. Hello, David. Good morning.
Hi, good morning, everyone. Good morning, commissioners. Thank you, Commissioner Cutler, for kicking us off today. So I think we can dive right into our first agenda item, which is an annual update on our registration of provider organizations program. And the staff will walk through a reminder of the program, where some of the decisions we made last year in terms of relief, reporting relief, and what our plan is for this year to update a few things based on the COVID-19 pandemic. So I don't know if I'm turning this right over to you, Liz, or if
Yes.
Great. Take it away, Liz Reedy.
All right, thank you, and good morning, commissioners. It's been a while since we last spoke with you about the Registration of Provider Organizations, or RPO program, so we included, as David said, a few overview slides as a reminder about what data we collect and how data are used before we update you on the 2021 filing. RPO is our first in the nation data collection program through which the Commonwealth's largest health systems annually submit information about their structure, relationships, and operations, and we make that data available to the public. It's a joint program with CHIA and incorporates the required elements of both the HPC's and CHIA's statutes. To date, we have collected information on corporate, contracting, and clinical relationships, lists of owned facilities, physician rosters, financial statements, and information on payer mix. Next slide, please. Most of the data we collect is made available on the program website, as you'll see on the next slide, so we don't always know who is using it. But we do know it has been used by researchers, providers, payers, state and federal government agencies, but likely the list of users is even longer. Over the last nearly 7 years, teams at the HPC have used RPO data in conjunction with other data sets, such as the All-Payer Claims Database and confidential information from MCNs and CMIRs to produce analyses about provider organization performance variation and the impacts of mergers and acquisitions, among other things. The information collected is fairly basic, but it's fundamental to our ability to answer important questions about Massachusetts providers in a systematic and standardized way, such as which hospitals does a particular system own, which providers do they negotiate payer contracts on behalf of, how is the system governed, how much influence do they have over participating members, does the system own any urgent care centers and where are they located, how many physicians are in the network, are those physicians employed by the system, how has the system performed financially over the last 3 years. Next slide, please. As I mentioned, we make the data available to the public. So for each filing year, we have an Excel file for each provider organization with the data they submitted, and we aggregate the information for all provider organizations into a master Excel file each year. We also post relevant file attachments such as corporate organizational charts. We also have a master physician roster, which includes each physician participating in at least one payer contract negotiated by a registering provider organization as of January 1st of the filing year. The roster includes data such as the physician's name, NPI, license number, specialty, practice sites, and medical groups. We also created a master file that answers questions about provider contracting relationships in a user-friendly manner. For instance, you can use the file to identify which entities within a system negotiate payer contracts, the owned and affiliated entities that participate in the contracts, the payers with which the entity contracts, and the types of contracts negotiated. Lastly, we make data notes available for each filing year, which identify any changes to the filing requirements for that year, for instance, new questions added, or changes to the registering entities, for instance, flagging if two organizations merged and are now submitting a combined filing. All resources shown here, except for the physician roster, are available on the HPC's website, and the physician roster files are available by request to hpc-rpo@mass.gov. Next slide. Now we will transition to sharing information on the current filing, but before that, I'll just note that we did not require a 2020 filing due to the COVID-19 pandemic. The only requirement for 2020 is an updated physician roster, which can be submitted along with provider organizations' 2021 filings, or if providers prefer to submit in advance, they can email their 2020 physician roster at any time to hpc-rpo@mass.gov. Next slide. We will be requiring provider organizations to submit a 2021 filing, which will be due on September 30th, 2021. We'll be posting the data submission manual with the data elements and filing requirements for the 2021 filing on the program website in the coming weeks. We also anticipate that the online submission platform, the site provider organizations use to submit their filings, will be opening in July. It will be pre-populated with data from the 2019 filing, so provider organizations can go in and review and update prior information submitted rather than re-entering their data each year. We will notify provider organizations via email when the data submission manual has been posted and the online submission platform is open. We're also preparing pre-filing checklists for each organization. These are resources we prepare each year that provide customized guidance on how to complete the filing based on an organization's previous filing. And lastly, I'll note that program staff are available for one-on-one meetings with provider organizations to discuss any questions on how the filing requirements apply to their specific organizations. We also have the added benefit of being able to use Zoom this year and can help walk users through how to update information in the online submission platform, for instance. Next slide. In terms of content, we made a few updates to the financial statements file this year. These updates align with comparable updates made by CHIA to their financial reporting requirements. To better understand how federal and state COVID-19 relief funds impacted the financial situations of provider organizations, the RPO program has added 2 new data elements to report federal and state COVID-19 relief funding and a new schedule to collect more detailed information on the funds received. As a reminder, provider organizations that have submitted annual standardized financial statements for the most recent fiscal year to CHIA are not required to submit the information separately to the RPO program if those financial statements are available from CHIA. We work very closely with the staff at CHIA to avoid duplicative reporting of financial information. And as I wrap up, I would just like to acknowledge and thank my colleagues, Tom Hash and Alexa Pava, who work very closely with me on the RPO program helping to prepare all of the resources for the 2021 filings, providing technical assistance to provider organizations throughout the year, and generally making the program run smoothly. I'll stop there and see if there's any questions.
Liz, thank you. Would this be useful? Is there anything in here that would help us understand which providers might be thinking of merging or closing or making other material change notices in light of what's been going on the past year or so?
Potentially in looking at their financial information, although I think it's more helpful in understanding prior mergers, acquisitions, and even smaller transactions, looking at the position roster, for instance, looking at who's added positions, who maybe has had positions leave their network in the last couple of years.
Liz, I just want to say how pleased I am at the level of your attention to decreasing the burden on the reporters. You really being careful about that, and I think that's terrific. What percentage of the information can be pre-populated, just out of interest?
I would say, I think about probably most of our files can be pre-populated. The ones that I could think of that aren't pre-populated are the financial statements, which change every year, the physician roster, although my understanding is that organizations, now that they've had to submit physician rosters for a couple of years now, have processes on their end and know what data we're collecting and what to expect. So even though the data are changing each year, they can pull it fairly easily on their end. And then the payer mix file, which is similar to the financial statements, is also not pre-populated, but the majority of the information, corporate affiliations, contracts, facilities where we know the information doesn't change much year over year, is pre-populated.
Thank you. Thank you.
Liz, do we observe, have we done any trend look to see, for example, what's happening to the number of physicians in different size organizations?
We do have a data points available on the website where we looked at trends between 2015 through 2018. And off the top of my head, I don't remember the actual results, but we do have information looking at changes for, I think it was maybe the top 8 or 10 contracting networks, and how physicians between 2015 and 18 have changed and moved throughout those networks. So whether they were retained by the organization that they were in 2015, moved to another large provider organization in Massachusetts, left, perhaps retired, for instance, and so have been looking at some of those trends.
That's terrific.
David, a quick question. Do we have 100% participation by those healthcare organizations, or do we still have organizations that are not complying with the request?
Liz, you can take this one.
Sure, we do have a couple organizations that haven't fully submitted the requirements for the RPO program.
I'll just add that we have very, very strong compliance with provider organizations over the history of the program. There have been occasions where a provider organization may object to our or SHIA's authority to collect a particular piece of information, but those have been few and far between.
Thanks.
So Liz, I found the data points, thank you. The share of PCPs in the 10 largest provider organizations rose from 2015 to 2017 from 87 to roughly 89, and then basically held steady. And the same was true at specialists. So it seemed like there was some increase that seems to have slowed off over time. which I don't know what we make of it, but thank you for doing that. Any other comments from fellow commissioners? Oh, David Seltz, you did post the link. Thank you. Any other comments from fellow commissioners? Thank you.
Great. So I will help tee up the next agenda item here quickly. So we're going to shift gears now and spend the remainder of our time walking through some key results from our 2020 healthcare cost trends report. And if you could move to the next slide. This is an unusual year for our cost trends report. As commissioners may recall, typically we issue the annual cost trends report in January or February of every year, and uses data that was submitted by payers and providers in the previous calendar year. This year, however, we've had to shift our reporting schedule based on the fact that SHIA shifted their requirements for all of that reporting into the state, and that what usually happened in early summer was shifted to the fall. And so basically all of our timelines as we've gone through this year have been shifted a little bit. So typically we would release the report in January and February. This year, and on a move forward basis, we can expect that the report will be released and finalized in June and July based on the new data reporting schedule. What we've done this year, though, is we've actually presented to this board and to the public a lot of the key findings already from the cost trends report, whether you knew it or not. We did a number of findings about the state's performance against the benchmark at the healthcare cost growth benchmark hearing in March. We had a number of findings that we discussed at the last board meeting in May on access and affordability by income. And what we're going to present today is really findings from our 5 chart packs. And so these are areas where we have done research pretty much every single year in our cost trends report on key metrics of hospital utilization, post-acute care, alternative payment methodologies. This year, we have a new section on price trends and variation, but these are typically metrics that we try to update every year and to have readily available chart packs that walk through the latest year of findings. So that's what we're going to focus on today. We're excited to present some of this new work. I will preview at the top that, again, most of the findings here are through 2019. So this is still reflective of a kind of a pre-COVID period of time, but are nonetheless very important metrics and for us to track. We plan to come back to the full board at our July board meeting to do the final presentation on the cost trends report, which will include a discussion of policy recommendations, which are annually included. So I think with that, Professor Cutler, I'd love to turn it over to our research and cost trends team to walk through some of these different topical areas. There's a lot here, so please feel free, of course, to interrupt, ask questions along the way. So I'll turn it over to David Auerbach to kick us off.
Okay. Thank you, David Seltz, and good morning, everyone. A couple of other notes before I get started are that also new this year, we plan to release the chart packs in a more interactive format on the web using Tableau for users to be able to go into the data, to see the data points on the graphs, to perhaps toggle on and off different things. And so that is in the works, and we hope that will be another way that this report is more accessible to the public and to all of you. And also, I'll just say I am presenting today, but my full team is on the Zoom virtually behind me, and I will take the opportunity if needed to phone a friend as it comes up. Okay, so as David said, most of the data today is through either 2019, if it's based on discharge data from GIA, or in the cases of using the APCD, it is generally through 2018. A reminder, our APCD data cut includes Harvard Pilgrim, Tufts, Blue Cross, and also Anthem and NHP, now called Always. And I know that we did see some 2020 data earlier as part of the COVID-19 study, but that was preliminary. And in any case, next year's cost trends report should be very exciting because we will have 2020 discharge data, and we hope to have 2020 APCD data. So kind of jumping ahead a year, they have really ramped up their data collection processes. And so we'll be able to have lots of interesting results through the pandemic next time around. Okay, so let's move on. All right, so the presentation today will be the Chartpack highlights. It's not the full Chartpack data, but just highlights, and it's going to be in in 4 sections, as you see below, starting with the hospital section. Okay, so to start us off, this is the long run trend in hospital use in Massachusetts compared to the US. We have always been above. This is inpatient hospital discharges per 1,000 residents. And you see here that gap has pretty much remained the same lately. We use the hospital about 8% more than the US average per capita, flat in the last few years. And though we don't have this graph on here, we also do have data on hospital outpatient use, where we are much higher than the US average, about 40% lately, 40% more hospital outpatient use than the rest of the country. Okay, next slide. This chart is showing, of all that inpatient hospital volume, who's paying for it? What's the split, Medicare, commercial, and then Medicaid and self-pay in the yellow? And the thing to note here is that as the years have gone on, the share that is Medicare has been gradually ticking up, whereas the share that is paid for by commercial payers has been gradually going down. In 2019, the latest year, only 28.9% of hospital stays were paid by commercial payers. And the Medicare share is approaching 50%. That is certainly an important trend to keep in mind as we think about the very big difference in payment rates coming from those payment sources. Okay. Next slide, please. Here we are tracking ED use in the state. And in a bit of good news, ED use has been gradually going down since 2016. You can see in blue is total ED visits per 1,000 residents, gradually going down through 2019. And even if we look at avoidable or BH-related ED visits, those are also ticking down very slowly. Next slide. When it comes to readmission rates, yes.
David, just a note on that one. That's actually, it's very impressive, particularly in light of the opioid epidemic still raging quite strongly in Massachusetts.
Yeah.
So that suggests really that folks are doing some either terrible things, that is, people are not making it to the ED, or that folks are doing some very, very good things to keep people out of the ED and get more people in treatment and stuff like that.
Yeah, that's true. I mean, the opioid trend is a fraction of those ED visits there, and I think that they, I mean, Laura would know. I think that they've been relatively flat, although we do see within the opioid-related visits this increase in the disparity. Growing among minority populations, somewhat declining among white populations. Is that right, Laura? I'm not sure if you're on, but.
Yeah, that's, sorry. Yeah, that's accurate. We, for this time period, we do see it being kind of level, but within that level, it is disparate across populations, especially low income and communities of color.
Yeah, okay, so we'll have more on that. Great. On the next slide, tracking our readmission rates. Again, Massachusetts, our best comparison is in the Medicare program, and we have, and we're only up to 2018 here, but we did increase a bit from 17 to 18, whereas in the rest of the US, they have been flat. So that disparity, that difference, that gap is continuing to widen a little bit. All payer, the data in the orange is from CHIA, and we're about flat there. So no progress anyway. Next slide, please. In this slide, we are tracking use of community hospitals. And in the top line, we're showing the percentage of all inpatient stays that take place at a community hospital. And you can see that's been relatively flat up through 2019, just over half of all stays. But then when you track newborn stays, you see that those really have been dropping, and especially in the last few years, now less than half of all newborn stays are in a community hospital. And when it comes to tracking commercial stays, that is also dropping. The share of commercial discharges that happen at community hospitals is now down to 44%. And again, that's important for thinking about payment trends.
David, are we seeing a change in the number of community hospital beds in the Commonwealth? Is this a supply issue or just shift demand?
Yeah, we haven't tracked the beds specifically, but the top line suggests to me that it's really not very much an overall supply issue, because that's fairly flat. So it really is talking about the mix of stays that are happening in community hospitals are more of the public payer stays and less of the newborn stays.
Thank you.
Mm-hmm. Okay, next slide. Okay, and this is an update of a slide that I have shown before, where we're tracking commercially paid inpatient stays. And the trend that we showed last year is continuing, whereas you have higher and higher payments for commercial inpatient stays, up to 4.6 billion there. And the y-axis is showing the percent growth. So 20% more paid for commercial inpatient stays since 2013. And at the same time, that volume has dropped or is flat from 248,000 stays in 2013 to 218,000. So again, higher payments, less stays. And when you put it all together, what you have is 38% growth over this period in payment per stay, or 5.5% growth per year. And that is pretty high. And we have found in other analyses that 5.5% annual growth is divided somewhat evenly between a pure price increase and acuity increases. And much of those acuity increases seem to point to coding changes. Okay, next slide. Here we track the concentration of hospital stays into the largest 5 systems. And you see a substantial tick up in 2019 after that percentage had been relatively flat. And that is really due to the BI-LH merger, where you see that in the orange. And so by 2019, what you have is about 61% of all, and this is actually combining inpatient and outpatient care, so all hospital stays, 61% in the top 5 largest systems, an all-time high. And you can see the community hospital shares in those gray lines, whether they're independent or independent hospitals, independent non-community, and those have been flat, not surprising. Okay. And with regard to post-acute care, we continue to see the same trend, which is probably a good trend of the percentage of hospital discharges going to an institutional setting, like a skilled nursing facility, dropped again about a percentage point to 17% in 2019, whereas those going to home health increased about a percentage point, and about no change with those just going to home. Okay. Oh yes, and this is the last one of this subsection. Alternative payment methods. We also know from CHIA's report that there's really no improvement in the big picture in use of APMs. Here we break that out by the 3 largest payers, the other Massachusetts insurers, and then the national insurers. And what you see is, for example, the orange section are all of your HMO and POS members who are required to choose a PCP. And for Blue Cross, about 79% of those are in an APM by 2019, so slight growth. And also, then in the PPO, you have in the blue, by 2019, 44% of Blue Cross's PPO member months are also in an APM. That's an increase. So slight increases within Blue Cross. Then with Harvard Pilgrim and Tufts, it's more flat. Very few among the PPOs are in APMs. The other mass insurers, you see a bit of a drop there in the percent using APMs, and then the national insurers again continue to not use APMs. So add it all up, and the top line numbers are really again a stagnation in use of APMs, at least in the commercial market. Okay, so that's the end of that section. Are there any questions before I move on? Okay, so now we're going to be talking a lot about provider variation, and this is our RPO PV section. And to start this off, I want to show this divergence again that we've been tracking in unadjusted TME and health status adjusted TME. Because we're going to be showing the unadjusted in the next several slides. And again, we've talked about this before, but when you now look over the course of 2013 to 2019, this divergence continues where the average growth in unadjusted TME, and that's real dollar total spending, has been about 3.5% per year. That's the blue. Whereas health status adjusted or HSA TME has only grown 1.2% per year over this 6-year period. And as we've talked about before, the difference there is the risk scores. The risk scores are growing by the difference there by about 2.3% per year. And so that risk score growth really depresses the growth in HSA TME. And remember, the HSA TME, that is what's used for PIPs. That's growing 1.2% per year only. And we believe most of that risk score growth is due to coding behavior and not an actual worsening of the overall health status of the Massachusetts population. Okay, so keep this in mind. We're now going to be showing trends in unadjusted TME. And on this graph, I'll spend a second on it because it's a little complicated, but what we have displayed on the x-axis is unadjusted TME in 2019. That is total spending per member per month, based on what organization you have your PCP in. And you see there a pretty big range from around $500 per month to over $700 for MGB, Mass General Brigham. And they're really far out of the rest of the organizations. And they are sized with the size of the bubble proportional to the number of member months. Okay, so that's the levels in 2019. And note that is preliminary data from CHIA. We don't expect that to change very much. And on the y-axis, we're showing growth from 2016 to 2019, average annual growth. And you can see the benchmark 3.1 as a guide there. So on the growth axis, you notice that most of these organizations have annual growth that is above the benchmark. So now another observation here is you tend to see some of the smaller groups with lower TME on the left tend to have higher growth. And then you see this kind of declining slant where a lot of the medium to larger groups have a somewhat lower growth. And that's sort of a catching up or a convergence pattern. But really MGB is an exception to that pattern where they are really the only one with very high levels of TME and high growth as well, over 4%.
Is there any meaning to the saturation of the blue, or is that just?
No, that's just for a guide for the eye. Okay, great. Okay, so now for the next set of slides. So again, that previous slide was based on the total medical expenditures, aggregate data reported by CHIA, the TME, and it includes non-claim spending, for example. Now we're going to shift back to claim spending that we get in the APCD, where we do the provider attribution ourselves. We have the granular claims data, and therefore we can do more with it. We can do more analysis with it. And so again, we're showing by provider organization in this one, total spending, and this is total claim spending. You see pretty much the same patterns, and this is 2018 data. But now we can break it out. For example, we break it out here by category of spending. Inpatient in the dark blue, outpatient in the orange, professional in the yellow, and so on. So one thing I would note here, again, you see the same pattern. MGB is on the left, is substantially higher than all the other groups. You see Atrius and Reliant, low spending on the right. And as we've shown before, the biggest differential, the biggest driver of those differences are the outpatient in the orange, where the variation is about double, is about 2 to 1 between MGB, for example, and Atrius or Reliant on the right. Okay. And on the next slide, we then some more deeper dives into provider organization variation. This is ED visits in the light blue and potentially avoidable ED visits in the dark blue. And as we have seen before, BMC continue to have high ED visit rates. And this is commercial patients attributed to BMC physicians again. And on the right, you have Atrius with substantially below average and about half as high in some cases as the higher organizations. Okay, now a couple of slides on low value care, which we continue to track in 2018. Here we are using the same set of 7 measures. I think we've added one more compared to prior years. And again, a reminder, this is really just the tip of the iceberg of low value care. We've selected things that we have enough volume to be able to identify in the claims data. Of course, most of low value care you can't really identify in claims because it's hard to know, you don't know all the detail of the context of that clinical visit. But in any case, these are well-studied measures that we can track. And even among these things, we found more than 80,000 commercially insured Massachusetts residents received at least one of these low-value care services listed on the left. And we do see significant variation by provider organization in the rate of getting these things. And so I'll show that in the next slide, or the next few slides. This is showing the screening types of measures, T3 testing, stress testing, and vitamin D test. And here the organizations are arrayed alphabetically, but although you can't see it, obviously here the variation in total, if you sum up any of these screenings per 100 eligible patients who could have gotten them, the variation is about 2 to 1 between South Shore and Atrius physicians. And on the next slide, we are showing a few more of these measures. I think this might be the first time we're tracking receipt of baseline labs before a low risk operation or surgery, which have been found to have no benefit to the patient. And about 1 in 4, that's the orange, about 1 in 4 patients do get these baseline labs routinely. And that's something that, folks are trying to change behavior. It's often just done out of rote. And there is variation in all of these measures as well. And on the next slide, we combine the 7 low value services and add up the spending on these, on all of these in total per 100 patients. And in this case, you see that spending arrayed from left to right on the x-axis, and the number of members are again shown proportional to the size of the bubble. And so what's different here from the other ones is you have not only the rate of provision of these low value services, but also the cost, how much is being spent on them. And so when you do this, you can see MGB and WellForce on the right, Atrius on the left. And again, that's partly a function of those prices or payments per service, as well as the rate of them. Okay, so that's the end of that section. We're now going to go into the new section of price variation and trends, and we'll show a fair number of these because it's new and really has taken a lot of work by the team, and we're excited to show some of this material today.
David, can I just ask you one question on the previous section?
Of course.
So at various times in past years, we've shown these to the organizations and said, hey, look, you're on the right here. Do you really want to be on the right of this picture and so on? I wonder if it would be, obviously we haven't done that yet because we just did these. I wonder if it would be valuable going forward to think about doing that. Yeah. Sort of showing these to some of the folks and saying, here's where you are on this.
Yeah, that's absolutely right. We did find it valuable, and we had conversations with 4 or 5 provider groups that were previously, on the left end or the right end. We learned some best practices. We wrote about it. We heard from organizations who are trying to improve, and so I think that is again a good approach. Or you could also imagine a more, maybe a more organized conversation with numerous folks at once. I think anything like that would be helpful because really there is a good research track record on how to do less of this stuff. People know how to do it. There are EHR triggers, there's resident experts, there's technology is improving to a lot of it is just ingrained ways that people have practiced for years. So I think there is room for improvement here, and yeah, we'd be happy to talk about ways to maybe make that happen.
David, may I ask a question?
Yes.
Deck, around slide, you remember 26 or 25, I can't remember, the one that had the multiple blue saturation bubbles. You had that for unadjusted expenditures. Did you have the same diagram for adjusted?
We haven't made that. That's a good question, but it's absolutely, it exists and we have the data. And so if you would like to see that, we could.
Yeah, it's just going to be interesting to see how a bubble migrates when you compare it to.
Yeah.
So just as if you didn't have enough work, that would be interesting to see.
We do have that underlying, and it is interesting to see how the risk score growth is different across organizations. Who has more, who has less of that. I mean, one small issue I would say is that it's a little easier to combine to show the unadjusted trends the way we did, because you can naturally combine the payers. You can combine Blue Cross, Tufts, Harvard Pilgrim, and all the payers, because the unadjusted dollars are just the dollars. When we're combining across payers with the risk adjusted data, you have to make an assumption that their risk adjustments, we don't know. It's a bit of a black box. We're assuming that their risk adjustment methods are comparable. So, some folks who are purists might say, no, you can't do that at all. We have taken that liberty and made some assumptions. In any case, yes, we have that in the background and we'd be happy to show it.
Thank you.
And Commissioner, to this point again, there's implications for our PIPS review process. I think, as we discussed at the last board meeting, as the trigger to be referred to, the primary trigger to be referred to the HPC for continued review is on the health status adjusted TME growth. And so you may see that some of those bubbles migrate below the dotted benchmark line, and that has implications for our ability to review them. So a topic that we are definitely looking at very closely. The last thing I would just note on this work in particular here with the low value care, this is just a great example of how we're able to combine the APCD and the RPO program to be able to do this type of attribution, because without the physician rosters that we collect in the RPO program, we wouldn't be able to attribute a patient to a physician and then a physician into these bigger provider systems. So a great example of how the data works together to provide really insightful metrics. And as Professor Cutler said, where even the provider organizations themselves may not know where they rank versus other provider organizations, provides a real opportunity for them to say, I thought I was doing really good on this, and now that I see where I rank, maybe we need to spend some more time on efforts here.
Yeah, I think doing this in a non-accusatory way, just saying, hey, look, here's where we are. What would you like some help or something? I'm sorry, Patty, go right ahead.
I was thinking back to the ER visits and the avoidable ER visits. Do we have any data, or are we looking at the impact of the emergence of urgent care centers and how much care may be diverted to those? And are we counting, if a hospital owns the urgent care center, are we looking at that cost data now back in our cost of ED visits? Or I don't know how, because it's such a rapidly growing alternative to the ER. And I'm wondering if there's still a hesitancy on it, take up to urgent care versus actually going to the hospital for an avoidable cost.
fantastic question. I have a few thoughts on that. So the good news is that we have just begun a contract to learn more about the urgent care centers. We did sort of an informal data collection on them back in 2018, and we wrote a data points on this. We identified how many there were. Very rapid growth. There were about 150 of them in the state by 2018. I think there's more now. And we collect this data. We know something about the costs there. And we made this data available to researchers and the public, and a number have taken that up and done analysis on, does this growth in urgent care centers reduce ED visits? And the answer seems to be a little bit. That seems to be the conclusion from a number of studies. Probably not enough to really move the needle on ED visits, but some yes. And that's not I would say that's not the only way to measure the utility of urgent care centers in any case, but they do see that. But in this updated study, we're going to learn more about them. We plan to ask them about what services they offer. We know it differs quite a lot. What kind of patients do they serve? And we should be able to get more insight into that. And I'll also I want to note what we presented a couple of weeks ago was this CHIA's survey data, where from the patient perspective, we asked members, if you have a condition that could be treated in an ER or an urgent care center, what are some reasons why you might go to either? And we did find that lower income residents with commercial coverage were often saying, well, I'm just not sure if I would be covered at an urgent care center. They're unsure. I'm pretty sure about the ED, so I might go there, even if it's a potentially avoidable condition. And that's not an irrational fear. We've known sometimes people end up with a facility fee at an urgent care center, or sometimes they're just not sure what's going to be covered. And so these are all areas to continue to think about and work on that front.
Thank you.
Okay. Great. Okay, so let's move into the price section. Okay, so here we're going to be kind of dividing the world up into office visits, hospital outpatient, and then we'll go to inpatient within this section. So starting out, we're looking at the sort of the most plain vanilla visit in healthcare, evaluation and management visits. And this could be a primary care physician or a specialist, or it's all mixed together. And you see the different codes on the top. Those are referring to the shorter, less complex visits to the higher paid, longer, more complicated visits on the right. And those are just the codes. And what you see here is a couple of things. As we had suspected, the changes between 2016 and 2018, the changes in the volume of visits are in the yellow. And you see that the shorter, lower paid visits are decreasing in volume, while the higher paid visits in the yellow are increasing on the right. So you see a shift, and CMS and everybody sees this, a shift towards those higher paid visits. And we don't know if those patients are truly more complicated or need more time. We suspect probably not all of that. And then you also see in the blue the changes in the price or the cost of those visits, the price being paid. And again, you see that generally, as you go to the right, the prices are rising for those higher complex, for those longer visits on the right. So overall, this translates to an increase in spending for E&M visits over this period. Okay. On this slide, I'll walk you through it. We have arrayed a very large number of both office visits and hospital outpatient visit procedure codes. So very many of them. And we decided to create bins according to how much did the price change for this procedure between 2016 and 2018. And those bins are on the bottom, and you see the 0% line. So for example, just to the right of that 0, you see the percentage of codes that had a price change between 0 and 5%. And think of that as perhaps what we might expect, where over 2 years, if something rose in price at the rate of inflation, maybe 1 to 2% per year, which is sort of about what you should do if you're going to stay within the benchmark. That's kind of a typical price increase. And you do see that those are the highest bars. So about 20 to 25% of procedures had a price rise in that 0 to 5% range. So then what we do is we have the office-based codes in the blue and the HOPD, hospital outpatient, in the orange. So a few things to note here. You do see quite a few far to the right of this graph of price increases, 10%, 15%, even more than 20% price increases over the 2 years, especially for the orange HOPD. And when you add that up, as the title says, about 1 in 3 HOPD procedures had a price increase of more than 10% in just the 2 years. So that's a fairly high price increase. And when you average these all up and weight them by volume, you see a 6.1% average price increase for the HOPD procedures and a 4.4% average increase for the office procedures in the blue. Okay. Then we're going to take a deeper dive into some of the more common procedures. Here we have colonoscopy, GI endoscopy, and a typical kind of surgical pathology. And here we wanted to look at some of those that can be done in both the office and the HOPD, as we have done before. And the most important thing to note on this slide is just that very big difference in the price of these things based on where they are performed. For the colonoscopy and for the endoscopy, those HOPD prices are double what they would be in the office. And not quite as big a difference for the pathology, but still that kind of difference. In the brackets, we're showing the change in price from 16 to 18 within a setting, within a procedure. And you see those office prices dropping actually, which is kind of interesting. But on the whole, the vast majority of these things are performed in the HOPD, about 70% to 90%. But you do see perhaps there is some, perhaps there's some competition going on. Perhaps there's some more of them offices offering these and people shifting to office settings. We hope so, but it's a pretty small minority right now. Okay, next slide. Here along the same lines, we're showing very common, very standardized labs and very big price variation based on where they are done. Again, opportunities for savings. You see that when a lipid panel is done in the HOPD, it's about $33 compared to $14 or $18 if it's done in an office. And then below that, you see the percentages of where these are actually done. So about half of these are being performed in those higher cost HOPD settings. And again, for all these things, we're combining both the facility price and the physician price. It's all combined. So we have the full payment here. Okay, so again, on that trend of setting of service matters quite a lot. Okay, and on the next slide, okay, now we're shifting to inpatient, a few slides on that. We have the same array of spending changes. All the DRGs above a certain volume are in this graph, and we're just arraying again the price changes. So here you see an even bigger price increase than for the office and HOPD procedures. You have 9% average growth between 16 and 18. And again, quite a few, about half grew over 10% for each category of stay. Is there a question? Okay. All right, let's move on, but please speak out if you have a question. Okay, so that's the inpatient world. We're gonna have a deeper dive on this. Next slide, we're showing some of the more common categories of stays. We're showing both volume change from 16 to 18 and price or payment growth from 16 to 18 in the blue. All of these had a payment increase, and they're sorted in that way between 5% payment increase to 16% on the right. And I'll note here the phenomenon with sepsis that we have shown before, which is really the outlier in terms of a volume change of 13% growth. We have seen before that there is some fungibility or substitutability across categories where some things like cellulitis have been increasingly coded as sepsis. So there is that shift going on, but that continued from 16 to 18. Okay. On the next slide, we now have 4 slides where we're showing price variation, mostly in the levels, but will also show growth for some very common procedures across hospitals. And again, here we're including both what the hospital is paid and the physician or professional payment that comes along with that. Here we're showing mammography, a variation of 65% by hospital from top to bottom. You can see the ends there. And we've also color coded the hospital cohorts with the AMCs in the orange. Those are going to be clustered on the high cost, high spending end. Community hospitals in the blue and the teaching in the orange. Okay, so we have a series of these. That's mammography, very common standardized procedure. Okay, next slide. Okay, now we have colonoscopy. A greater variation from top to bottom of about 117%. In this case, you do have more of a mix across the hospital types, and you do see this phenomenon that not only is it the AMCs that tend to be the higher price, but sometimes the more geographically isolated hospitals. Here you have Falmouth and Berkshire Medical Center sometimes have higher prices as well. Okay, on the next slide, we're now getting to some inpatient procedures, major joint replacement, variation from 22,000 at Lowell General to 42,000 at MGH. And you can see the New England Baptist, in a special category. This is really one of their major things that they do towards the right or lower cost, lower payment end. But again, similar patterns by hospital cohort. And also, I forgot to mention, on top of these bars, we're showing percent change in price from 16 to 18. So in this case, you see that those hospitals on the left end, Mass General and Brigham, are the highest, and they've also had substantial growth in the last couple of years. South Coast as well. Okay, and one more of these, I believe. C-section delivery, again, similar story, similar pattern across hospital types. Mount Auburn is always a fairly low payment hospital for childbirth. They are on the right, 15,000 compared to 24,000 at Mass General. Okay. I think that's okay. That's the end of the price variation section. Are there any questions? I see I'm nearly out of time, or then I'll just quickly show you one thing in the dashboard if there's time. Okay, so the dashboard.
David?
Yes.
Colleen gave us dispensation to go a couple of minutes over, so you don't have to rush your sentences.
Happy for any questions on that price section then. Okay.
I thought it was utterly fascinating.
Great, I'm glad. Okay, and I can't wait to have more next year up into 2020. It should be very interesting to see what happened. Okay. Yes.
So, I mean, this is such a tremendous amount of data, and I always have the lens of the employer, the commercial market, that I would love to find a way to present this type of information to them, so they really have a deeper understanding of what's going on with their claim dollars.
I'm sorry, I'm having a little trouble hearing.
Oh, okay. Can you hear me now?
That's better.
Okay. Yeah, so I was just saying this is a tremendous amount of data, and I think it would be very enlightening for employers to understand how their claim dollars are actually being spent and how they can be best spent and what can be avoidable. So I just want to throw the question out, and I think David Cutler kind of alluded to it earlier on. How do we make this data actionable? Because you've done tremendous work here in analysis, but I'm afraid we're not maybe doing our job unless we can start to bring awareness to avoidable procedures or unnecessary emergency department visits. And maybe I'm way outside of my scope here, but I would hate to see this just sit there and not have us work with it. So.
Absolutely appreciate the comment and the push. And I think we have in the past been able to use some of this data to talk to employers about how they might have a role through either their employee engagement or through their plan design to be able to use some of this data to think about where those efficiencies and opportunities may be. As an example, we worked with an employer coalition on avoidable ED. And it really started, that this coalition started with one of these data books where we were showing the variation of rates of avoidable ED, depending on which PCP, you were going to, essentially. And that really sparked a whole level of conversations and opportunities to say, with employers, to then say, okay, how can we have a role here? So I completely agree. And I think one of the other areas where we've, hope to use this work and package it is with our sister agency, the Group Insurance Commission, who is kind of the employer coverage for the Commonwealth. And where we see these massive variations in either pricing or total medical spending, depending on where you go, there are opportunities here, especially when, and just reflecting on the slide in front of us, where there is, Mount Auburn, a very efficient provider for these for deliveries, and also very high quality. And so, okay, how might we think about what are the types of incentives and opportunities to highlight really high performing providers that are providing great quality care at a really efficient price? So I think I'll take the comment as both an encouragement and a challenge that we collate and kind of synthesize some of this data that makes it actionable for not just policymakers, but for market participants and employers as well.
Barbara, I see your hand up.
Yes, thank you, David. I think a couple of these slides reminds us of our very spirited discussion several months ago on upcoding, especially the issue of sepsis. And as I recall, we were intensely focused on that and really wanting to get a better handle on that and try to call that out. And I think especially the sepsis slide, but some others as well, reminds me of that. And I wonder how we might want to re-engage in that conversation.
I'll say that we do have some extensions of our earlier findings already underway, already in the works, and we hope to have more detail on that, such as variation by provider groups. Even as Dr. Berwick was saying, there is more we can learn, and we hope to have some updated results in a year on that or less.
Great, David. Thank you. I'm encouraged to hear that.
Yeah.
I wanted to just flag David Cutler's earlier idea about converting these data into conversations with these provider systems. I think that's dignified and important to do, and waiting annually for the cost trends hearings is a little bit slow. So I guess I'd put on the table, David Seltz and maybe Stuart, whether there's a way to create a dialogue that we and commissioners could engage in with these people, just to keep the conversation alive in a much prompter and real-time way.
Thank you, Commissioner. I think there are real opportunities to do that. I'd love to talk more with you about that.
Thank you.
Okay. Should we move to the last? Okay, great. So let's just show a little bit of this. As you know, one section that we've included with the cost trends report is a dashboard of metrics that are tracking various means of performance, whether as a state or as provider organizations, but pretty much, we are looking for Massachusetts comparisons to the rest of the country in both changes over time and in how well we are doing at something. And I want to note that this year, and you can see the categories, we have really added and enhanced the health equity category this time around. And I'll show you an example of what we're doing on that in the next slide. So you'll see on the top, for example, a number of measures that we do track. For example, individuals under age 65 with high out-of-pocket spending relative to income. And so we can see that overall in the state, we have a pretty good ranking and a pretty low percentage, 6.1%. But then we are able to dive deeper into that data and say, well, how does that look for separately for low-income individuals and high-income individuals? And when we do that, we see, wow, it's not surprisingly, but there's a very big difference of 20% of low-income residents have high out-of-pocket spending relative to income versus 0.07% of high-income individuals. So that's a disparity you could call of 19.3 percentage points. In terms of that disparity itself, we're actually not doing so well. We're ranked 31st. So we are one of the higher disparities among the states. So we will be highlighting not just how we're doing on average, but this disparity, a distribution, how are we for different populations in the state? And we can do that across a number of measures where we have the more granular data. So look forward to that. And on the lower part, not just by income, in some cases, we can break this down by race and ethnicity, for example. Infant mortality or mortality amenable to healthcare, as we know. Very big differences you see there among populations of different race and ethnicity. So this will be an ongoing feature of the dashboard and the cost trends report. Okay, and that's all I've got.
Just to sum up, David Auerbach, I mean, these are terrific. I think even with these, there's an issue about how do we make them actionable with in government, with market participants and so on, because it's just amazingly important information, and it could spark so many valuable discussions.
Great.
I'm wondering, Dawn, you've probably done more of this than the rest of us combined. Maybe Dawn, you could give us some, not the second, but maybe you could give us some thoughts about ways we might approach that.
I welcome that, David. I think you're really onto something important here. And David Auerbach and your team, I'm inspired and just awed by what you're doing. It's the best work I've seen of this type, but it just sits on a shelf as something interesting until we have an action system. And you know, I think psychologically data like this can drive action if it's raised in a way where dialogue is authentic and inquiry is deep. So David Cutler, I'd welcome a chance to think through how to do that.
Great. Maybe either at our next board meeting or at our next MOAT meeting, let's circulate things in between, and then maybe we can bring this topic up.
Okay.
That sounds great.
Okay. Any other comments from commissioners? If not, I believe, David Seltz, we've reached the end of our agenda for today.
We have. Thank you so much, commissioners. And here is the upcoming schedule. We are going to be reconvening on Zoom in 20 minutes for the meeting of the Care Delivery and Transformation Committee. But we'll turn it back over to you, David, to close out this meeting.
Very good. Thanks to everyone. This was just really fascinating stuff. So thank you to David Auerbach and your team. Thank you, David Seltz and Colleen. And we will adjourn now to come back to these issues some more, either in July or in October. And thank you to this. Yes, Ron, thank you to the HPC staff. Just terrific. And with that, I will adjourn. And in 20 minutes, we'll pick back up with the CDT.
Thank you.
Thank you.